Hello, everybody. Welcome to our webinar. This is the fourth in a series that we're doing on Medicare versus Medicaid. We have a lot of situations where somebody a little bit younger is concerned about one or both of those, and how do you qualify for both? So our panel is, there's four of us, and we've been doing this now, like I said, this is our fourth time. My name is Steve Schmidt. I'm an attorney with Carlson Burnett, and I mostly focus on long-term care planning and work with seniors, but there's a lot of overlap. And so we're going to be talking about the younger population today. We're going to start with David Thompson, and then we're going to start with, how do you qualify for Medicaid? That's fairly similar no matter what your age is. And then we're going to talk about, Stephanie's going to talk about life and financial circumstances and how they changed. And then we're going to have BevVan Phillips talk about skilled therapy, and we're going to do kind of a wrap up at the end. So looking forward to going through this with you.
Hi, everybody. My name is David Thompson, and I am an elder law attorney at the firm of Carlson and Burnett, where my practice focuses on things like Medicaid planning, veterans benefits planning, guardianships for people who can't manage their own affairs. And then I sometimes get involved in disputes within families or involving long-term care facilities and the kinds of issues that come up. So the theme of all of our panels, this is panel number 4, has been the relationship between Medicare and Medicaid. And I'm going to continue with that theme today, but I'm going to focus on one particular piece of the puzzle, and that is the time that people spend in skilled nursing facilities. How much, if any, of that time is covered by Medicare. So before I answer that question, I'm just going to remind everybody of the differences between Medicaid and Medicare, because it's useful to keep those differences in mind. So when it comes to Medicaid, Medicaid is a program for low-income individuals. There are strict asset and income limits that one cannot exceed if you are to qualify for Medicaid. Medicaid is a federally funded program, but it's managed at the state level. And in Nebraska, Medicaid is managed through Access Nebraska, which is administered by the Department of Health and Human Services. Now, the process for applying for Medicaid can actually be quite complicated. And those complications derive not from the person's health situation, but their asset situation, and in particular, whether they have any different kind of assets, such as an insurance policy, or maybe they own a piece of a family farm, or maybe they just received a large inheritance, or perhaps the proceeds of a lawsuit or something like that. These are all assets that have to be treated in a particular way under Medicaid regulations. So that's often what the application process is focused on. Now, when it comes to skilled nursing care, if a person qualifies for Medicaid, if they meet the income and asset limits, and they are in a skilled nursing facility, now that care is going to be covered by Medicare up to a certain point, but for low-income folks, everything after that is going to be covered by Medicaid, and we'll see how this works as I move forward. Now, Medicare is not a need-based program. You don't have to be low-income in order to qualify for it. As a matter of fact, most people who are on Medicare were enrolled automatically when they turned 65. Coverage begins generally the first day of the month on which you turn 65. So my mother was born on April 26th, so her Medicare coverage started on April 1st of the year in which, the month in which she turned 65. Now, Medicare is also federally funded, but it's also federally managed. So when it comes to understanding the rules regarding Medicare, you have to consult an organization called the Center for Medicare and Medicaid Services. That's the national organization that handles Medicare. As I said, the Medicare, the application process for Medicare is nowhere near as complicated as the process for Medicaid, and is in fact, most of the time it happens automatically. Now, when it comes to time spent in a skilled nursing facility, Medicare will cover a part of that care as long as it falls within certain guidelines. And those guidelines are going to be what I talk about with the rest of my presentation. Now, as everybody knows, Medicare has lots of different pieces. There's Medicare Part A, Medicare Part B, Medicare Part D, Medicare Advantage policies, Medigap policies, and it's really not necessary for me to go into that kind of detail, especially because Stephanie, one of our other panelists, knows a lot more about that than I do. But I do want to make a distinction between Medicare Part A and Medicare Part B. And sometimes we talk about somebody having original Medicare, and what that means is that they have Part A and Part B. Now, when you're in a hospital, when you're receiving inpatient care in a hospital, Medicare will cover all of that under Part A. But when it comes to skilled care that somebody is receiving in a facility, Medicare will cover that, but only for a limited time period. And the rest of it's going to be covered by Medicare Part B, which covers lab tests, x-rays, ambulance services, durable medical equipment, and that kind of thing. There's also home health care that is sometimes covered. If that home health care is medically necessary, then it will be covered under Part A. But if it's not medically necessary, then usually it's what we call custodial care. And custodial care is care that is really aimed at helping somebody with their activities of daily living. And when I'm talking about activities of daily living, I'm referring to bathing, toileting, transferring from bed to the chair, ambulating, feeding yourself, those kinds of things. And the care that is aimed at helping somebody with those activities of daily living is considered custodial care, and therefore is not covered by Medicare. So when it comes to the stay in the skilled nursing facility, what does Medicare pay for? As I said, that there are certain guidelines that that care has to meet, and they're generally time guidelines. So first of all, there has to be what Medicare refers to as a qualifying hospital stay. And a qualifying hospital stay really means any stay in a hospital of 3 days or more. If you are only in the hospital for 1 day or 2 days, then you do not qualify for Medicare coverage of your time spent in the skilled nursing facility. But if you did have a qualifying hospital stay, then the first 20 days that you spend in the facility will be covered by Medicare at 100%. So from days 1 through days 20, Medicare will cover that 100%. After that, really, and that means days 21 through 100, from that point on, the patient has to pay a coinsurance, but the rest of it will be covered by Medicare. But when it comes to the period after that, really from day 101 going forward, Medicare doesn't cover any of it. So to the extent somebody does not qualify for Medicaid based on their income, then that care provided on day 101 going forward is covered through private pay or sometimes through a long-term care insurance policy. And then when it comes to custodial care, as I said, Medicare will not cover that at all. Custodial care is only covered by Medicaid. And that, as I said, those for people who meet the income requirements. So when you're looking at any particular situation, as I hope my presentation has demonstrated so far, there's a few key questions that you need to focus on. Question number one is, was there a qualifying hospital stay? Did the person stay in the hospital for at least 3 days? The next question is, what kind of care were they receiving? Was it skilled nursing care or was it custodial care? And then the question is, how many days of care did they receive? And that question can be a little more complicated than you might think at first glance, because that 100 days can be broken up over different periods of time. You can spend 20 days in a skilled nursing facility at one point in time and 20 days, or let's say 30 days in the skilled nursing facility at some other time. Now, those all fall within that first 100 days, but they're broken up over 2 periods of time. And how much of the benefit period gets used up in those kind of circumstances, again, depends on whether there was a qualifying hospital stay. And sometimes there has to be a second qualifying hospital stay if we're talking about a different point in time. But in general, the benefit period is 100 days. And so every time someone is in a skilled nursing facility, they use up a certain number of days in that benefit period. So with that, I'm just going to do two quick case studies before we move on in the panel. So the first one involves Mr. Adams, who has a fall in his home and then spends 2 days in the hospital and then is sent to a skilled nursing facility for a week of rehab. So who pays for Mr. Adams' care? Well, if you ask the first question, was there a qualifying hospital stay? The answer in Mr. Adams' case is no. He was only in the hospital for 2 days. So inquiry stops there. You don't have to proceed any farther. He did not have a qualifying hospital stay. Therefore, Medicare will not cover any part of his time in the skilled nursing facility. And if he doesn't qualify for Medicaid, then as I said, the person will have to cover that care through primary private pay or long-term care insurance policies. So let's hope that Mr. Adams either qualifies for Medicaid or has the resources to do private pay or long-term care insurance. And then let me turn off my timer here. The second case study is a little more complicated. We have Mrs. Perkins, who was in a car accident, and as a result of that car accident had to spend a week in the hospital, and then she was sent to a skilled nursing facility for an additional 10 days of care. So the question there is, who pays? So was there a qualifying hospital stay? In this case, the answer is yes. Mrs. Perkins was in the hospital for a week. So then she was in the skilled nursing facility for 10 days. And then she went home for a while, but then had to return to the skilled nursing facility for 5 more days of therapy. So this is one of those situations where the number of days counting towards the benefit period it's broken up into 2 pieces, 2 parts, 2 points in time. There's the first hospitalization or the first time in the skilled nursing facility that happened after the car accident. And then there was the second stay in the skilled nursing facility when the doctor ordered Mrs. Perkins to return for additional therapy. Now, these are 2 different points in time, but they count towards that 100-day benefit requirement because the second hospital stay occurred within 30 days of the first hospital stay. So as I said, when that time period is broken up, there's oftentimes there needs to be a second qualifying hospital stay, but not always. So those are the case studies that I wanted to focus on. And with that, I will stop my part of the presentation and say thank you very much for listening.
I'm going to be talking today about how do you get started on Medicaid. Again, I'm Steve Schmidt. I'm an attorney, do a lot of this. So how do you pay for long-term care insurance? And again, this doesn't really matter what your age is. Long-term care insurance is a great tool. Some of my clients that I work with have it, but a lot of them don't. If you don't have long-term care insurance, the next thing you start looking at is private pay. There's a few other things that we look at from time to time that aren't as common, but those are listed on the slide there. So we're gonna touch a little bit on some of those later in the presentation. So let's look at the eligibility. So really there's a couple of factors. One is age, and then the other 2 have to do with assets and income. So age, again, is not a big factor if you're over 65, but if you're below 65, the age becomes a little bit more of a tricky thing. So there we have to look at disability, and there we have to typically go through the Social Security process to see if you're actually disabled under the Social Security definition. So it's a little bit different if you're under the age of 65, and it's a very specialized way that we need to look at that. Then we look at the assets. So like I said, the other 2 things are assets and income. Income is almost never a factor in Nebraska. We're going to be talking about Nebraska here, although we do work some in Iowa. But in Nebraska, income is almost never an issue when we're talking about seniors. It may be an issue if we're dealing with somebody fairly young, but for seniors, it's never an issue. And if we have a married couple, it's almost never an issue. On the asset side, though, we're looking at a couple of different things. So we're looking at countable and we're looking at non-countable resources. Those are kind of the big things. A single person can have, say, $4,000 of countable resources, And then we have some non-countable resources, sometimes like a house and a car and a few things like that. So let's look at when we're doing some planning, what do we look at? So here's some numbers. And if you want a handout with some more numbers on them, we can certainly send those to you. We've given those to everybody that's participating live. And so these are some of the basic numbers, though, that everybody should be aware of. So the individual resource allowance, we mentioned that, $4,000. And then for a couple, it's $6,000. Now, as far as the income side, you can actually keep $60 of your income. Everything else has to go for your cost of care. So $60 plus $4,000, again, not a lot of money there if you need to go on Medicaid and need some long-term care help. We're going to be talking some about the spouse resource allowance. There's a maximum and a minimum. So a minimum means if you're married and all you have in assets together as a couple is $26,000, you get to keep every nickel. If you're over $130,000, then we have to come down to that $130,000 level. I'm just going to kind of show here on my board, if you can see that here, what that looks like. So if you're a married couple, and let's say you have 260,000 or more than 260,000 assets, we split those assets in half, or our DHHS splits those assets in half for us. So we tell them, here's our assets, they split those in half. Again, we have some exempt assets. We have like a house and a car. We may have some business assets, a very, very small life insurance. So there's a couple of assets. The ones we deal with most are the house and the car. So the $260,000, we split that in half. And what DHHS says is you can keep $130,000 of assets if you're the stay-at-home spouse or the community spouse. If you're the Medicaid applicant, if you're in a facility, have in-home cost of long-term care, then you have to spend down assets. And the most you can keep, again, is the $4,000. So again, this is a critical thing if we have a married couple, no matter what the age, is to look at those assets and how do we take care of those assets. So let's look at some of the others. So let's look at long-term care insurance. So there we go, long-term care insurance. So there's been a couple of innovations in long-term care insurance here recently. You know, if you're one of the fortunate individuals that bought a policy maybe 15 or 20 years ago, and you still have it, it's probably a great policy. A lot of the policies that we see that are older are really, really good policies, and you don't want to give those up. A lot of times we have newer policies, though, where it's a little bit different. And here's some of the newer innovations on that. So the partnership qualified policy was really wonderful when it came out. We don't see those as much anymore, but it allowed us to keep some additional assets over and above what Medicaid normally said. The one policy that is really popular today that we really like and we encourage people to look at is the hybrid policy. It's a hybrid between life insurance and long-term care insurance. So one of the complaints about long-term care insurance is if I die and I never spend it, I just wasted all that money. Well, with a hybrid policy, we know that if you don't use it for long-term care, somebody's going to get the benefit after you pass away. So those can be a really good benefit. So then let's talk a little bit about the VA benefits. We're going to have another webinar on this, but I just want to touch on this because you have to be aware, if there's a veteran involved, we have to look at VA benefits when we're doing any type of long-term care planning. So here's just some of the basics on that. So let's keep going here. So next is a spend down of assets. So, you know, if we're trying to qualify for Medicaid, one of the first things we look at is if we have too many assets, is there something that we can or should spend on? So a lot of times I'm talking to individuals, they haven't, you know, they've gotten behind in some area. They've gotten behind in fixing up their house. They've gotten behind on some bills. And they've gotten behind on mortgage. So different things like that we look at when we're doing some Medicaid planning, because we got to be really careful about giving assets to family members or to even a charity. But if we spend money taking care of the person that's going to apply for Medicaid, that's perfectly fine, and we do that all the time. In fact, you can even pay attorney fees and stuff like that. So there's ways to spend money to benefit the individual that we want to look at in a lot of these situations. So let's talk again about the spousal impoverishment, or let's look at the deprivation. There we go. So in the deprivation, there's a look back period. So again, we talked about what if you gift assets to a family member, to a child or another family member, or what if you gift assets to a charity? There's a look back period for Medicaid, which is 5 years. So if you do any type of significant gifts to your kids or anybody else within 5 years, Medicaid wants to know about that. And it goes into the calculation that we have to do and how to get you qualified for Medicaid. A lot of times people think that, hey, if I made a large gift within the last 5 years, I can't do anything. That's not necessarily true. We just have to be aware of it. We have to plan around it. So there's a penalty when you do that. A lot of times when we do Medicaid planning, we actually do gifting into a trust or some other type of way. And there's a penalty associated with that. The penalty doesn't start until we actually do an application for Medicaid. So be very careful about making gifts until you talk to somebody that knows how to do this planning, because it can really mess up the opportunity to do good planning and actually get benefits if you don't do this well, do it wisely. So let's go to the next one there. So here we're talking about if we have a single or a married individual, and this is non-crisis. Well, what do we do? So let me first say what crisis planning. Crisis planning means we have a lot more or more, but usually it's a lot more expenses than we have income. So you have to have a lot of in-home care, or you have to go to assisted living, and your income is way down here and your expenses are way up here. We call that crisis. Well, we like to do non-crisis planning. So if we know that potentially we're going to have to look at Medicaid or large long-term care expenses, we want to do non-crisis planning. So this is kind of how we do. We go through all these different things. We look at the income, expenses, the gifts, and then we look at, if they have long-term care insurance, and we a lot of times do a trust and talk about gifting and caregiver agreements, those types of things. And annuities, we deal a lot with annuities. You got to be really careful on annuities. There are some providers that say, hey, we have a Medicaid compliant annuity, and it may be, but if it's not set up correctly with the plan, it can still make a big mess. So you got to be really careful with annuities. You want to make sure you're working with a professional that understands how the annuities work together with good Medicaid planning. And these are just some of the basics that we have to look at. It has to be irrevocable, non-assignable, sound actuarially, fixed payments, and then have Medicaid as a beneficiary, which simply means that if you get Medicaid benefits and there's an annuity out there, Medicaid annuity out there, the first payment goes back to reimburse DHHS. And okay, so trusts. I mentioned trust briefly. We use trusts a lot. And so a trust is a really good way to protect some assets. So whether it's a single individual or a married couple, one of the things we look at is a trust. How do we protect some assets? So again, ideally, we put some assets in a trust more than 5 years before somebody goes on Medicaid, or sometimes we have another person set up a trust for that person. A lot of times we may have a parent, and that's a special needs trust, a little bit different than this maybe, but it's the same concept. So again, if you have a child with special needs, make sure you look at an irrevocable trust, a special needs trust. But an irrevocable trust can also be used for a person who is trying to get on Medicaid. And these are kind of the things that we look at when we're doing that. So spousal impoverishment, I touched on that a little bit. I'm just going to touch on it again. Again, what I said before, if you have $26,000 of assets or less, you get to keep every nickel if you're the stay-at-home spouse or community spouse. If you have more than 130,000 assets, we have to do some planning. And one of the ways we do some planning is with an annuity. So we can actually take the excess assets over here from the Medicaid applicant spouse that is supposed to be spent down. We can take the assets that are excess of the 260,000 and we can buy an annuity. So one of the magic things about annuities, when it's done correctly, is we can convert assets into income. And so it's a way to get more assets back to the community spouse or the stay-at-home spouse and still qualify sooner rather than later for Medicaid. So estate recovery. You've probably heard a lot about that. Some states are more aggressive or proactive in estate recovery. I was very proactive. They go after assets on a regular basis. Nebraska, not so much. But Nebraska does require everybody who handles an administration after somebody passes away to notify DHHS. So they do recover some assets there. So just in conclusion, don't apply for Medicaid until you do some planning. Unless you have no money whatsoever, then go ahead and do it. But if you have some assets you're trying to save, or you think there's a potential of preserving some assets, make sure you talk to a qualified professional about that. There's only a few attorneys in Nebraska that do that, and a few attorneys in most states. So make sure you get good planning in place before you take too many steps and before you do gifting.
Yeah, good afternoon. Thank you. My name's Stephanie Swerczek, and I'm the owner of Simplified Financial Solutions. I'm an independent insurance agent that assists seniors and people with disabilities, help to navigate their Medicare options and Medicaid spend down if that's something that they need, as well as marketplace solutions. I just wanted to talk to you today kind of to tie in what David and Steve have talked about, how to qualify for Medicaid and what that looks like, and then Medicare and what some of those benefits will sometimes, cover as far as skilled facility care and additional programs. So I wanted to talk about when life and financial circumstances change. I have a client, her name is Sally. She's 63 years old. I helped her, this was been last year, so the numbers are going to be a slightly different, but the concept's still the same. So she's 63. She is intellectually disabled, but she lives in Nebraska. Sally was living with her parents because of her disability, and she was receiving supplemental security income in the amount of $771 a month. That's the amount that's increased a little bit since then, but she lived with her elderly parents, but was able to attend an adult day program 5 days a week, which was super fulfilling. She loved going. She had friends there. In addition, it gave her elderly parents a little bit of a reprieve. They needed a little break from being her full-time care provider. So it was a really great fit. And that continued, and everything went along just fine until Sally's parents passed away. And Sally then became eligible for her father's Social Security, which raised her monthly income to $1,372. When Sally's parents passed away, she moved in with her sister, and they received notice that Sally was losing her Medicaid benefits because she was now over the Medicaid income limit by $311. So Sally's sister was of working age and had a job and still needed to be able to maintain that income because she was now Sally's new care provider and they needed that income. So they tried for as long as they could to continue to pay for the adult day program. It was $50 a day, so it's costing them roughly $1,000 a month, which was taking up most of Sally's income, leaving them very little to pay for her other needs. So when I was contacted, we worked together to find some health insurance policies that were accepted by Medicaid. There's some that are allowed coverage and others are disallowed. So we found some health insurance policies that cost $315 a month. So by spending that $315 a month, she once again became eligible for Medicaid, and they were able to restore her benefits, and she was able to go to the adult day program again. So she was very happy. The sister was very relieved because that was a very important service that she was receiving. So by spending $315, they were virtually able to save that $1,000 a month that they were paying. So the net effect for savings was $685. This is a really common strategy that I help people with. Sometimes I'm contacted by people who have lost their Medicaid benefits because they're $4 over the spend down limit. And it's very simple fix. It can help them get a vision policy that's, $12 to $13. And all of a sudden their benefits are restored. And so it's always good to know that for people just to be educated that, there's a simple fix and that all hope is not lost. So thank you very much. And I'm going to pass it over to BevVan, who's got some additional case studies to share too. Thanks.
Thank you, Stephanie. Again, I'm BevVan Phillips. I'm an occupational therapist with Key Complete Therapies. And I'm excited to talk to you today about some differences between Medicare and Medicaid and how skilled therapy services are delivered, maintenance programs are carried out, and how non-covered services are provided. As we begin, I just want to go over a couple of concepts to make sure we're all on the same page. Today, I am talking only about physical therapists, occupational therapists, and speech and language pathologists. There are other therapists whose services are covered by Medicare and Medicaid, but these are the three services that Key Complete Therapies provides, and these are the services that we know the most about. I want to point out that what Medicare, Medicaid, and other insurances pay for does not include everything that therapists are educated to do and licensed to do. Insurances pay for what that insurance company considers medically necessary. In addition to that, some therapists have education, certification, licensure in fields outside of their OT, PT, or speech education, and those services can be delivered to people but are not considered skilled care. So they are not covered by Medicare, Medicaid, or other insurances. And then I've been talking about skilled or skilled therapy. And to define that, you just need to remember that the definition is defined by the payment source. So typically it's going to mean the skills of a therapist are necessary to safely and effectively furnish the recognized therapy service for that payer. Three more important definitions is to understand the difference between rehabilitation, maintenance, and habilitation. So in rehabilitation, the primary goal is to restore an individual's abilities. So you know the person is going to be improving in response to the therapy, and that they're going to make that improvement in a reasonable and sort of predictable amount of time. Maintenance, you're not expecting an improvement in skills or function, but what you're trying to do is reverse the loss of function. And for insurance companies, that still needs to be carried out by a skilled therapist. In habilitation, your primary goal is to help a person develop skills they have never had, that other people in their age bracket have developed through normal developmental processes. And habilitation as an aspect of care has been phased out of most medically based funding systems. So now let's compare and contrast Medicare and Medicaid and how skilled therapy begins and continues. We'll talk about Nancy first. She has Medicare and she wants to receive therapy on outpatient. So she's using her Part B of Medicare. So as soon as Nancy realizes she has a need for therapy and there is a prescription from her physician, therapy can begin right away. Nancy and her therapist develop a plan of care, which includes, among other things, the goals, what you're working on, frequency, how often you're going to work on it, and how long you're going to work on it. And the plan of care demonstrates the need for skilled therapy. The physician certifies this. There is sort of a seamless start and continuation process. There is an annual cap for services. So Nancy needs to understand that there's a dollar limit to the amount of therapy she can receive. And that dollar, that pile of money, if you will, or the limitation bucket is OT is in one bucket and PT and speech are combined in another. The other aspect is that if Nancy has a lot of therapy needs, there is a process by which therapy can continue if it is medically necessary. And Nancy's service can be rehab or maintenance as long as a skilled care is required. And Nancy is going to have some co-pays and some co-insurance. So Nancy's going to have some financial obligations with Medicare only. We'll look now at John, who has one of Nebraska's Medicaid insurance products. And when John recognizes the need for therapy and there's a physician's prescription for an evaluation, the therapist office needs to submit to John's managed care organization, his MCO, request for a prior authorization to do the evaluation. So there is the opportunity there for a little bit of delay in service while waiting for that prior authorization. When the prior authorization is received, the evaluation can occur and a plan of care is put together with the goals, frequency, duration, and that information is submitted once again for a prior authorization to initiate treatment. So there is, again, an opportunity there for a little bit of time delay between deciding what therapy is needed and how long and what you're going to do and when you can actually begin. The number of visits that John has is 60 visits per year if he's 20 and on Medicaid programs. And this is PT, OT, and speech combined. So there is the chance that if he has really significant therapy needs, he'll reach his 60 before the year is over, and his therapy will need to stop if it's to be paid for by Medicaid until the year begins again and he has a new 60 days to work with. John can receive rehabilitation only, and of course the physician is involved with that referral, the plan of care, and any appeals that need to occur. So now we'll take a look at what Adam, who has regular Medicare and regular Medicaid, does. When he starts therapy, he's not going to have a prior authorization. So when he recognizes the need for therapy and he gets a physician's order, as soon as the therapist is available, he can begin. It's just like starting with Medicare. And there are no prior authorizations to, keep on going. The Medicare cap, that dollar amount, is in place, but not the 60-day Medicaid limit of treatment. And then as far as financially, Adam is going to have some financial responsibility. Medicaid is going to pay 20%, his co-insurance, up to the managed care organization's allowance. So it is possible that Adam is going to have some cost-sharing responsibilities for co-insurance and copay. And then finally, let's look at the fourth situation with June, who elected to have a single policy. So she didn't keep regular Medicare and Medicaid, and she elected to have a single policy administered by an insurance company. So when June recognizes the need for therapy and there's a physician's referral, she does not need to wait for prior authorizations to start or to continue treatment after the evaluation is done. It's handled like Medicare, but there is no Medicare dollar cap and there is no Medicaid 60-day limitation of treatment. And again, that's Nebraska Medicaid. So that June does not have any financial responsibility in the service delivery. So there's 4 situations: Medicare, Medicaid, regular Medicare and Medicaid, And then finally, the fourth, a dual policy. And you can see the differences in how skilled therapies started and continued with each of those. Now, several times I talked about maintenance. And I know that those of you listening to me, some of you are going to say, well, I'm really confused about that because I had no idea that Medicare could cover maintenance. And you're not alone. Many therapists are unaware that Medicare can cover maintenance as long as it's delivered by a skilled therapist. And the reason for that confusion is that for many, many years, there was an improvement standard, which we all accepted as rule of thumb. And I'm going to share with you a case study. Mrs. P had amyotrophic lateral sclerosis, ALS, Lou Gehrig's disease, and that is a progressive neuromuscular condition that leads to end of life. And she was told by her insurance carrier for Medicare, that she was not going to be covered by Medicare because she had no potential for improvement. So Mrs. P, along with some other individuals and 6 national organizations who serve people with disabilities, brought a suit against the Centers for Medicare and Medicaid Services, which was settled January 24th in 2013. And the result of that was clarification that it is not a person's ability to improve that makes them eligible for Medicare. It is the need for skilled service that makes them eligible for Medicare. So Medicare does cover maintenance programs under 2 circumstances. And you need to understand this is only for services delivered by the therapist, not by any of the assistants who are educated and licensed in our professions. So the first scenario is Medicare will cover periodic reevaluations by a therapist of the patient in order to design and adjust and retrain others to carry out a maintenance program. So you need the therapist to make sure it's still appropriate and to train others. The other situation is when you need the skill and the judgment of the therapist to actually do the maintenance program. Nebraska Medicaid in practice, we've found that we are not able to do maintenance programs because the process that we go through to deliver services to Nebraska Medicaid, we have to submit and request that prior authorization in which we are demonstrating that we're going to have an improvement in function. So an improvement in function is rehabilitation. We cannot prevent or do maintenance. So there is that very stark difference between Medicare and Medicaid in Nebraska as far as maintenance is concerned. And then finally, let's touch on those services that therapists are qualified to provide to patients and clients, which are not going to be covered by the insurance company, either because that insurance carrier doesn't cover it or because it is a service that is outside of the scope of skilled care. But this is done. People can receive the services they want to receive as long as there is clear communication about it. And this is done through the Advanced Beneficiary Notice, ABN form. It's a Medicare form, but other insurance carriers can use it. And you are very clearly saying this particular service is not likely to be covered because of these reasons, and this is how much it is probably going to cost you. And then the patient or client has some options to take about billing related to that. And that is a way of making sure that you have protected the patient. You have let them know that they are liable for those services, but people can receive services that are not medically covered by their insurance company. You for joining us. On behalf of the regular panel who provide these webinar series, Medicare, Medicaid, or both, for individuals under 65 or who have disabilities, we appreciate your listening to this and sharing this information with others who can use it. We hope you'll look for our next webinar in the series, which is taking a closer look at some shared living services and day programs for individuals using Nebraska Medicaid. And if there are any things that our panelists can help you with in relations to information delivered in today's webinar or in general on Medicare, Medicaid, or both, please don't hesitate to reach out. They are here and willing to help you.